Good morning. Good afternoon. Good afternoon, everyone. My name is Luca Giorgini, and with Vanessa Cainghug, we are co-leaders of a special interest group for psychotherapy for youth mental health. This symposium is an activity of this group and is sponsored by the Psychotherapy section of our Psychiatric Association. This group was born in 2019 when we accepted the invitation of the board WPA Psychotherapy section and of Professor Demétrius França, that is also from yesterday the new president of World Federation of Psychotherapy, to develop an international research group that brings together experts in developmental psychotherapy from all over the world. Our aim is to be an international network to debate and disseminate the best practice in the field and favor the establishment of the worldwide research network. Despite the slowdown in our group's activity due to the pandemic, this is the third meeting after Manila in 2020 and WPA World Congress in Bangkok in 2021. And we will join at the WPA Congress in Vienna, scheduled for September-October. We hope to be there. The present symposium is called Psychotherapy in Developmental Years, New Challenges for Youth Mental Health in the Post-COVID Era. We have a speaker coming from all over the world: Brazil, Philippine, Czech Republic, China, and Italy. The deep and widespread impact of the COVID pandemic on the quality of life of adolescents and young adults is an issue of major concern. Despite the generalized optimism that overcoming the acute phases of pandemic would have brought back in a substantial normality, we woke up in an entirely different scenario. Several characteristics of clinical conditions that were initially silent, with the progressive resuming of more intensive social interaction, produced a tangible increase in the demand for mental health care. For example, eating disorder or increased suicide attempts. Vanessa will tell us something about this. In this spirit, the symposium will discuss the topicality of the youth mental health in the current post-pandemic phase. Now I will present the first contribute is from Vanessa Cainghug. She is the president of Philippine Society for Child and Adolescent Psychiatry, head session of the Child and Adolescent Psychiatry at St. Luke's Medical Center, Global City, and training offer section of Child and Adolescent Psychiatry at the Medical City. The title of Vanessa's speech is A Tale of Two Lives, comparing two suicide attempts during COVID-19. Please, Vanessa.
Okay. Good afternoon, everybody. I would just like to share what I have been doing the past 3 years, working with children and their mental health problems during COVID-19. So the title of my talk is A Tale of Two Lives, comparison between two suicides during the COVID-19 pandemic. I have no disclosures. Prior to COVID-19, we were already experiencing the steep rise in mental health problems among adolescents and young people in the Philippines. Top disorders were depression, and which of course we all know lead to suicide and suicide attempts, and anxiety. These numbers might seem old, but I wanted to compare them with the present statistics. Prior to COVID-19, there were already quite a big number of Filipinos with depression and anxiety disorders, and there was already a notable number of suicide cases. And during the pandemic, we all know that in 2020, it was the first phase, the preparation phase, and then came the punctum maximum phase, the second phase, and then I I would like to assume that we are now in the return to normality phase. And the two cases I will be discussing happened in 2022. And I think that was already part of the third phase. Okay. Now these numbers came from a study in the Philippines by Michael T. He said that during the early phase of the pandemic, there was a reported 28.8% of Filipinos with moderate to severe anxiety, 16.9% with moderate to severe depression, 16% with saying they had a mental impact of crisis with moderate to severe degree, and 13.4% with moderate to severe stress. Now, the psychological impact was higher in those with higher levels of stress, anxiety, and depression. And these were the factors which contributed to more stress: female gender, adolescents, single status students, presence of physical symptoms of COVID, recent imposed quarantine, being quarantined, prolonged stay at home, poor health status, too much unnecessary worry, concern about family members, and feeling of being discriminated. This was during phase 1 of the pandemic. And the following factors led to a lesser impact and lower levels of stress, anxiety, and depression. If the patient had timely and accurate health information, those with children older than 16 years old, a perception of good health status, and confidence in their own healthcare providers. Now, this data in the Philippines came from the National Center for Mental Health, which is the largest government-owned mental health facility. This slide shows the big increase in calls at the NCMH, or National Center for Mental Health hotline, during COVID, from 400 prior to COVID to 700 during the phase 1 in 2020. And this is how their hotline looks like. So people from all over the country would call the National Center for Mental Health when they have mental health concerns. Okay, now look at this. This table shows only 392 suicide-related calls compared to 3,000, almost 4,000 total calls. But in 2020 to 2021 February, it increased to 1,935 suicide-related calls over 12,375 total calls. Okay, and from 2021 to January 2022, a total of 7,694 suicide-related calls over 21,115. So you can see the very high rise in the number of suicide-related problems in the Philippines. So this is a summary. This is 2019 prior to COVID, 2020, and then 2021. Okay. Now, we all know these factors which were consequences of the pandemic, which led to increased suicide rates, the social isolation, disruption in healthcare delivery. But I'd like also to mention that in the Philippines, or a majority of psychiatrists were able to transition to online therapy and online consults. So it took some time, a few months, but we were able to transition and we were able to deliver healthcare services all over the country. But other factors were sudden changes in daily routines, being trapped at home, increased risk of abuse, and prolonged experience of the pandemic, almost 3 years. And I would notice that when I travel abroad, I noticed that here, like here in Casablanca, it seems that COVID is already over. But when you go to my country, you can still feel that there is still people will still practice health protocols very much, and there is still a concern over COVID. Okay? So now let me present two cases of suicide attempts which happened in 2022. Both in one in the first quarter and the other in the one in the second quarter and the other in the third quarter of 2022. These cases are both similar and different. Okay, let me start with case of A. A is a 15-year-old female who was admitted to a private hospital due to multiple pelvic and lower extremity fractures secondary to a non-accidental jump from a height of 4 floors. She was previously diagnosed with a number of psychiatric disorders, bipolar disorder, attention deficit hyperactivity disorder, and I wasn't able to write there, a learning disability. Okay? She was doing a homeschool program prior to the suicide attempt, and the triggers were non-compliance with treatment because the treatment was disrupted because of COVID. She had to move to another part of the country, and she had to adjust to another home setting because she was living in another city, and because of the pandemic she had to move there. So the treatment was disrupted. And she also experienced a lot of stresses also related to COVID and to her family. I will discuss the family issues later. Now, the case of B. B is a 15-year-old female also admitted due to multiple pelvic and lower extremity fractures secondary to a non-accidental jump from a height of, again, 4 floors. Both patients survived. Okay? Case of B was previously diagnosed with major depressive disorder which started in 2021. This was still at the height of the pandemic. This patient was, as differentiated from case A, was doing well in school and had a good support group, both from family and friends. The triggers were the stresses from COVID-19 and for more than 2 years, and the stopping of her treatment for her depression. However, her family is very stable and very supportive. Now, let's compare the two cases. They are both 15 years old. A is homeschooled while B goes to a regular school. The reason for admission are similar due to pelvic and lower extremity fractures secondary to the jump. And A had quite a number of psychiatric disorders while B only had major depressive disorder. Now, contributing factors. For A, again, the follow-up with her psychiatrist was disrupted due to COVID-19, sudden changes in school and home environment, and a family crisis. For case B, there seemed to be no triggering factors, but it was just the prolonged experience of the COVID pandemic. Now, going to A, because she was already experiencing a lot of stress, and then on top of it all, the family suddenly experienced a crisis because her parents had a big marital issue when her mother learned that the father was having affairs and had children with other women. So her family became disrupted and split into various groups. Okay? Now, their length of confinements were similar, more than 4 months. They stayed in the hospital for more than 4 months because of the medical condition. Now, but this might seem very tragic cases, but the suicide itself actually had a positive factor in their therapy because for case A, despite the animosity in her family, they were all forced to stay in one room in the hospital. So family sessions were done almost weekly, even to extended family members. Okay? And for case B, her family was able to change their interaction with the patient positively and to show her support during the duration of her admission. And her friends also were there to support her. Now, I experienced several challenges as a psychiatrist for these two patients. There was a time, about 2 months, when they were both in the hospital and I was seeing them both. Okay? My challenges for case A for both patients was the difficulty with the therapy because of their physical condition. They had extreme discomfort, especially during the first 2 months, such that I could only do very short therapy sessions with them because they were very uncomfortable and I had to compete with the surgical procedures which happened almost weekly, especially for case A. Another big challenge for case A was the complicated family dynamics. Since the patient was a child, therapy involved establishing myself as a constant attachment for the patient, particularly case A. I could sense that her family was the biggest hindrance in forming a therapeutic alliance with the patient. I felt that her family was so protective of her and so worried about any outsiders who wanted to get to the patient. So I had to peel each hindrance away and until I could reach the patient. I started with the mom, the dad. I had to deal with the grandmother, the grandfather, her brother, sister, cousins, and even her nanny. That was before I could establish a therapeutic relationship with her. I had to get connected with these people and had to get them on my side because they were all worried of me. And remember, each family member was also at odds with some of the other family members. So the whole family was actually divided into various camps, which were at odds with each other. So the family structure was indeed very unique. Okay? And in the midst of all these conflicts, it was so difficult to be neutral. Okay? I had also several mishaps in the therapy. So the path to the patient was really a convoluted one, but slowly with hard work, I was able to establish a therapeutic relationship with the patient and also with most of the individual family members. A factor which helped me also was the prolonged hospitalization of the patient because I could see her most days of the week and her core family again had to stay with her in the hospital and they could not escape to their private safe spaces which they used as coping for this stressful family dynamics. At present, the patient is doing much better, not just physically, but also I believe with her psychiatric status. Physically, she is now able to walk with assistance, which was almost impossible to do at the start of her admission. The therapies I employed for case E were CBT, psychodynamic psychotherapy, and stress debriefing of the family, siblings, and cousins, and also numerous family sessions. For case B, her case was much simpler than case A, so I only did supportive therapy for the family and CBT for the patient. Now, these two cases are very similar at the same time very different, but both of them, the suicides I believe came about because of the big factor of COVID-19. For case A, it was because the family was disrupted by the marital problem of the parents and the patient felt that she had no escape since they couldn't go out of the house because it was at the height of the isolation due to COVID, such that she felt that she had no choice but to jump from the fourth floor. Okay? Now both of them are doing much better. And conclusions, COVID-19 really had a big impact on young people's mental health as seen by statistics from numerous studies. The effect of COVID-19 was observed in the two cases presented, although they had different backgrounds and family dynamics. With appropriate care from a competent team of healthcare professionals, the prognosis of the two cases is good. Thank you. Now, let me be the one to introduce, because I'm also part moderator in this symposium. So now I'm going to be the moderator. Let me introduce the next presenter. The next contributor is pre-recorded because unfortunately Professor França could not be with us due to organizing problems. Professor Demétrius França is a psychology professor at the Federal Institute of Brasilia, or Brazil. He is author of 2 books and papers about peripatetic therapy. He is also elected counselor at the Regional Psychology Council. Professor Demétrius França will discuss what to do when a teenager doesn't respond to conventional psychotherapy, a peripatetic therapy experience. Please now the video can start for Demétrius França.
Hi, greetings from Brazil. I'm Professor Demétrius França at Federal Institute of Brasilia, Brazil. First, I would like to thank the organization of this Congress for allowing me to participate in this way. I also would like to thank Luca, Giorgini and Vanessa Cainghug for the organization of this roundtable. Since we are short of time to do our presentations, I'd like to start presenting my patient profile. He was 13 when he had a crisis inside his school, and he interrupts his studies without detailed information about what happened. The adolescent would present depressive episodes and complete social isolation except for his family. He does conventional psychotherapy for 3 months but without any results and starts to see a shrink which helps to alleviate the symptoms, but he remains without return to school. After 3 months of refusing to speak to the psychologist, the professional ends the process and suggests the service of a psychologist specialized in peripatetic therapy. That would be me. Peripatetic therapy is defined as a psychotherapeutic technique that adapts psychological theory to the context of mental health, using the notion of territory and space to provoke new and old affections in substitution of conventional clinical settings. This practice started as a reaction to patients that would not respond to conventional treatments in mental health during the second half of 20th century here in Brazil and Argentina. Even today is more popular in Argentina and Brazil, is getting more popular in other countries of Latin America, but we present very strong results. I would like to present the case evolution. The peripatetic therapy happened twice a week with a phenomenological perspective. The first session consisted of 15-minute short walks with the family dogs. The teenager would speak of Facebook banalities, but at the end of the walk he was so exhausted that he would leave without saying goodbye. I tried to encourage him to speak about what happened to him, but he would always react by closing the session because he was feeling bad. Parallel to his reaction to sensitive themes, I could observe how intrusive his parents could be, imposing clothes, hairstyle, and judging his hobbies. I understood that his peripatetic sessions should be his safe space, should be as light as possible to allow him to feel safe. As the patient started to feel more comfortable, the sessions became longer, to last longer. We started to visit quiet places without a lot of people, like nature parks, where he would observe birds and small animals. It's very while we would speak about any banality he would like to, like video games, Facebook, etc. It's very important to point out that this adolescent never spoke to me about what happened to him, but during our sessions, he started to feel stronger and stronger to go to crowded places like movies and bowling. During these sessions, he slowly started to speak directly to the waiters and cashiers instead of asking me what he would like, showing me that he was feeling safer to perform social interaction. Parallel to his engagement in peripatetic therapy, he managed to gradually return to the regular classroom with a lot of ups and downs, but consistently advancing. He finished his first school year under treatment with homeschool, but the second year he managed to have regular classes during the first semester, but with some pressure from his parents to have extra credits. He may have a regression and he came back to homeschool during the second semester. During his third year under treatment, he managed to have regular classes during the whole year, going 2 to 4 days a week to class. After almost 3 years, he evolved from complete social isolation to making new friends. We had to interrupt the peripatetic therapy when he was 17 years old, but we present strong results in a very delicate condition where the patient couldn't speak about the apparent trauma he suffered. I'd like to also speak just a little about how physically in the beginning, he would not allow people to touch him. He was very fragile. And after some months, he would touch me without noticing. He would not react this way as he would react during the beginning of the treatment. And feeling safer and safer to speak to me, he started to feel safer to speak to other people. And it's very interesting to think in this pandemic world because if peripatetic therapy is based in the use of territory, sometimes when he was too exhausted or not interested in going for a walk, sometimes we would speak while he was playing a video game, and we would speak about the space, the game strategy, and how he was dealing with the frustration any game can present to the gamer. To conclude, I'd like to quote Minkowski, the French psychiatrist, who was a strong critic of diagnosis based solely in description of symptoms instead of understanding the patient and his perspective. In this case, it's very interesting because even the psychiatrist didn't propose a final diagnosis for this adolescent. After almost 3 years and a half, the psychiatrist is starting to speak of autism, but who knows? And in this case, I would like to add another information. As Minkowski says, sometimes you need to have the patient reconstruct his emotional barriers instead of performing conventional therapy. Thank you for your attention. These are the results of a paper I published at Synthesis Philosophica in 2020. Thank you.
Thank you, Professor Franca, for this passionate lecture. Next speaker is Katerina Duchonova. She is a psychiatrist and psychotherapist based in Prague, where she works in the Department of Child and Adolescent Psychiatry of Thomayer University Hospital and the Center of Crisis Intervention for Psychiatric Hospital Bonn. Her main areas of interest are trauma-focused psychotherapy and transcultural psychiatry. She participates in psychotherapeutic project for refugees, migrants, and people in social need in the Czech Republic, Africa, and in the last year we were traumatized women and children from Ukraine. She is a board member of the Psychotherapy section of the WPA, and Katerina will tell us about crisis intervention for youth and young adults in times of social change.
Good afternoon. Thank you for coming to our session. So my presentation will be about the system of psychiatric care, about children and adolescents in the Czech Republic, which is also very limited. I will explain you something about the reasons, and then also something about the system of crisis intervention for young adults. So, my country, the Czech Republic, has approximately 10.5 million inhabitants, but you can see that the expenditure on mental health care in my country are not sufficient. The costs directly by mental and behavioral disorders are only 3 to 4% of expenditure on health, which is one of the lowest number in the whole European Union. We are also facing the consequences of our totalitarian past in the Czech Republic. So it was in the past, Czechoslovakia, maybe in the world, is the country still more known as Czechoslovakia, but we divided into 2 countries, Czech and Slovak Republic, 30 years ago. But there is still the persistence of asylum type care, and we can observe only slow changes towards modernization. So the mental health care system, it's still based on the huge psychiatric hospitals, which are still the basic providers of the psychiatric care. After the Second World War and during the communist regime, only minimal changes were made. There were some network of outpatient clinics established, some day clinic for anxiety disorders, especially in Prague, and some psychotherapeutic programs in some departments of mental hospitals. But then after the fall of communism, so 3 decades before, the psychiatric care is unfortunately still concentrated in these big mental hospitals. There aren't so much small psychiatric departments as a part of general hospitals. Outpatient psychiatrists are often very overloaded and have long waiting times. It depends, but usually it's from 2 months till half a year. The community services are still inadequately developed, and there are some, but they are carried out mainly by NGOs. But some strategy for the reform of psychiatric care exists. So we are now developing more community services, mobile teams who are able to come directly to homes of the patients, and I think that's the goal, to help the patients and to provide the interventions directly in their natural environment. This means in the families, or in the case of children and adolescents, also in the schools, for example. Yeah, here is also something on this slide about the influence of totalitarian past, about the persistence of institutional care, prevailing paternalistic approach in education, healthcare, still insufficient consideration of individual needs. Also, stigmatization of mental disorders still persists. There's a lack of psychotherapeutic care, and especially for children and adolescents. And now in the new era, there are deepening social disparities, also deteriorating social status of some parts of society, much easier availability of drugs and pornography and other things than in the past, also influence of modern technologies, of course of COVID pandemic, and now also of the high influx of refugees. I read in the statistics that we have the highest number of war refugees from Ukraine per capita, because we are a small country. As I noticed before, we have 10.5 million inhabitants, and now we have around 1.5 million Ukrainian refugees, and most of them are women and children. And here is something about the system of children and adolescent psychiatry, which is also very insufficient. We have only about 120 specialists for children, and located only in certain regions of the country. There is also the fact that half of the psychiatrists are of retirement age. Waiting periods for examinations are very long. So the psychotherapeutic care especially is often not available, sometimes not covered by health insurance. We have lack of specialists with training in family therapy, and lack of services of psychosocial support for dysfunctional families. But the prevalence of adverse childhood experiences in my country is quite high. So you can see this cross-sectional survey conducted among some selected universities students. So the numbers of emotional abuse, of parental violence, physical abuse are quite high. And almost 10% of respondents reported experiencing even 4 or more types of adverse childhood experiences. And in Czech, as we have many children with mental health issues like anxiety, hyperactivity disorder, but also many children with self-mutilations, with eating disorders, and the number of these patients is rising. So especially due to the COVID pandemic, the children and adolescents suffered of social isolation, of disruption of their daily routines. They were also closed on a small space with the whole family, and many of these children are also from very dysfunctional families. Many cases of domestic violence occurred during this period, and we had one of the most longest lockdowns during the COVID-19 pandemic among the states of the European Union. So that's why also the children had long periods of online education. And we have 4 crisis centers in Czech Republic with non-stop operation, where psychiatrists, psychologists, and therapeutic nurses are available. But these two of these centers are in Prague, and the other ones located in other big towns of the Czech Republic. But we have only one crisis center for younger children, and it's a center with very limited operation. Then we have also several crisis lines for anonymous help, which are very useful, I guess, and as we are trying to develop the community care for children and families in need. So we have recently established also one mobile crisis team for vulnerable children and their families. Yeah, it gives something about the crisis, commonly in the young and the young adults. I was talking about it already. So the young and children are suffering of divorce, separation of parents, of their own relationship difficulties, loss of some key figures in their life, of loneliness, inability to form relationships, of role confusions. They are searching for their own identity. In the schools is very often bullying, including also cyberbullying. Dependence of technologies is also very often. And the children and youth are suffering also of the fear of the future, strengthened by the pandemic, the war in Ukraine, the economic and energetic crisis in Europe, and of environmental problems. Here is some model for a crisis intervention. So it's important at the beginning to plan and conduct crisis assessment, and establish a rapport and rapidly establish a relationship, identify major problems of the clients, deal with feelings and emotions, generate and explore some alternatives, develop and formulate action plan, and then in the end to make some follow-up plan and agreement. So basic interventions are listening, empathizing, building rapport, offer some options or generate solutions, work together to change the dysfunctional behavior, look for some social support. There are some benefits, like early identification of problems before intensive psychiatric care is needed, because the psychiatric wards are overwhelmed already. The crisis intervention may prevent and intervene early to diminish the illness, emotional behavioral health crisis. It can help discover internal and external psychological resources, allow catharsis by releasing emotions in safe environment, helps to find alternative solutions of the problem, strengthen some positive coping strategies. And the future goals are to expand this network of crisis centers, especially for children and young people, develop community care, including these mobile teams, raise awareness, provide widely available psychotherapeutic care, so family therapy, enable therapeutic help more accessible in schools and universities, and minimize unnecessary use of acute care settings in the psychiatric hospital and some residential treatment facilities. say this picture
for your well-articulated lecture. And the last presentation is again pre-recorded by Dr. Zhengjia Ren, who unfortunately couldn't be with us because of the COVID travel restrictions in China. Dr. Zhengjia Ren is Associate Director and Associate Chief Psychiatrist of the Department of Clinical Psychology at the Third Affiliated Hospital of Chongqing Medical University. His research interests include dialogue among culture and mental health, as well as the development and promoting indigenous mental health services in China. Dr. Ren will discuss about confusion of tone, Chinese teenagers and their families, communities and cultures in the context of globalization. Now let's listen to Dr. Zhengjia Ren's video.
Dear friends and colleagues, it's a tremendous honor for me to join the World Congress of Psychotherapy online. Today I come to share with you some of my clinical experience to working with Chinese teenagers and their families. You can say China has changed a lot during the past 20 years. As the rural population slowly moved to the city, as we can say from the chart, since 2010, China's urban population is higher than that of the rural population. This reflects that China has entered a rapid development stage of urbanization. This background information reveals to us that China is going through a lot of changes nowadays. China has always been a community and collective-centered society, where people care about each other's appealing collective values and family pride, rather than individuals' feeling and needs. But there is a tendency of change during today urbanization. Take a look at the power distance map. In the power distance map, it comes to show to us that the people who is in the position of higher social status, who has higher power. It reflects a patriarchic and hierarchy society. So in this kind of society, everyone has to fight for power. This has something to do with the requirement for teenager in the Confucian culture. Chinese culture emphasized that men are superior to women, in which men are expected to be more confident, ambitious, and successful. They had a very clear gender role. They pay attention to their masculinity. This cultural ideology still has a profound influence on how teenagers say themselves. One study comes to predict that China's economy will account for 28% of world GDP by 2030. This change has brought a lot of impact on the life of every citizen in China. But we have to be very careful. Look at the data of mental health of children and adolescents in China. The study shows that the prevalence of mental illness among adolescents in China account for 17.5% compared with 13% worldwide. The development of economy has brought a lot of obvious mental distress. The study comes to show the non-suicide self-injury rate of college students is much higher, around 16.6%, which is much higher than the percent of worldwide. The factors that contribute to the mental health well-being of teenagers, including that the pace of life, the gender factors, the family relationships, and the academic stress, and the issue regarding to sexuality. So we can say that Chinese Confucian culture influence that. You have to have very good score to bring honor to the family and to be very highly successful, bring a lot of pressure to the teenager. That causes a lot of stress. So the mental health problem of a teenager is become a very serious public health issue. So let's look at the suicide ideation and no suicide self-injury. So in my clinic working, every day I will say like 20% of the teenagers, they had some kind of issue regarding to non-suicide self-injury. So let's look at the incidence of suicide ideation among teenagers. It's around 32% of the teenagers, they had a suicide ideation. 2.7% of them who had commit or try attempted suicide in the past year. So the prevalence of no suicide self-injury was 19.5%, and that of intention self-injury was 14.2%. So there are some very serious public health issues, suicide and non-suicide self-injury. Another thing is about the LGBTQ adolescents, their mental health being. As we know, in China, 4.1% of adolescents they self-reported as sex minorities. 17.3% were unsure about their sex identity, gender identity, or their sex orientation. As the research comes to show to us that the people who have same-sex romantic attraction and bisex romantic attraction, they suffered a lot. They had much higher suicide attempts, suicide ideology than their counterpart. So the study comes to suggest that Chinese sex minority adolescents are at increased risk of suicide than general population. As we know, China is a family-based society. In the past, Chinese family emphasized having more children. But due to the one-kid policy, now many families only have one children. Parents will have very high expectation for their children, and both parents and children are very anxious. This is the community I was lived. In traditional Chinese community, everyone knows each other, play and does things together, and there is a sense of belonging and more connection. But now in the city, everyone in their own like a cave. I call it a cave. So they don't know each other. They don't know their neighborhood. We don't connect each other. We don't contact each other. Our only connection is through our cell phone. We don't know who we are, who we belong to. The modern lifestyle also brings a lot of confusion to teenagers. In China, there is a word called 内卷. What means 内卷? 内卷 emphasized competition between each other in order to get better grades and honor for their parents and also to themselves. Everyone needs to compete from childhood to adulthood, which makes them miserable and anxious. We did a very important study based on this. We interviewed adolescents and their parents. We asked their parents, what do you think is causing your kids' self-injury behavior? The parents think it's because rebellious, they learn to be bad, weak willpower. So we also asked the same question to the adolescent. The adolescent come to show to us because they interpersonal stress, because they learn about some new information, like what they wanted is love, caring, connection, understanding. But that's very strange for their parents. They need their independence rather than submissive. And they also reported to us their growing pain. Some of them found it's a disease. As we know, the ideology of their parents, it's originally from their education. They grew up in a patriarchic society. In a society, pay attention to filial piety, traditional gender role, family reputation. This ideology deeply influenced the thinking of their parents, which bring a tremendous gap between parents and the adolescent. So they don't know each other, even though they live in the same room for many years. We also interviewed the parents of sex minorities and asked them what they thought caused the problem of their kids. Many parents mentioned to me, based on the theoretic model, they feel like it's an inner problem, like they have some bad thinking. So if they change their bad thinking, they will be good. Their bad personality, their rebellions. Or some parents feel so guilty about their education. They feel, oh, maybe it's because my education is wrong. Maybe it's because the family relationship caused the sex orientation or gender identity issue of their children. Maybe they think it's a bad influence from outside, from the internet, from America. So that two ideology deeply shaped that they hope their kids come to change their sex orientation or their gender identity, or to hide, or they will abandon their kids. As we know, their ideology deeply shaped by the traditional Chinese culture, the binary gender role, traditional gender role, heteronormative culture, filial piety culture, carry on the family line culture. Even though many teenagers think it's pretty normal to be gay, to be lesbian, to be transgender, but that's tremendously challenging for their parents. So that brings a tremendous gap between parents and their kids. Based on the understanding, we designed a model. We often tell these parents that either you and your child need to change, or they need to stay sick. First, we work with the parents. We try to help the parents to understand the needs and the difficulties of adolescents. We try to understand how the culture to shape the parents' educating ideology. Try to bring some self-reflection of the parents. We also did some psychoeducation for the parents. So to bring some new information to the parents, maybe the depression of your kids is a disease rather than the bad personality, or rather than she, learn something bad. We also try to find the missing tie of the family. There is tremendously miscommunication and misunderstanding. We try to reduce the patriarchic function. We try to bring more equal relationships, more intimately, more caring, more connection in the family, rather than pay attention to the traditional patriarchic and hierarchical relationship. So we also empower them to face their difficulties together. For the sex minorities, we build called culture-sensitive service, called the 6-step counseling strategy for LGBT families. First, we emphasize with the parents' pain. We provided some scientific and clear knowledge to the parents to share with them what it means to be gay man, what it means to be lesbian, what it means to be transgender, to provide the scientific knowledge to them. We also try to switch the perspective, help the parents to understand their child's pain. We try to also to build a cultural narrative. In the past, the culture pay attention to the marriage and continue the family line. Right now, we invited the parents to think about the happiness of their children, to think about the traditional lifestyles and right now the modern new lifestyles act. We encourage the parents to listening more about sex minorities, encouraging both parties to consider each other's reputation. So our working is try to reduce the confusion of tongue, to reduce the confusion among the family, try to bridge the gap to build more deeper connection, deeper understanding. We emphasize each other's pain. No one is easy. We try to increase understanding and decrease misinformation and misunderstanding among the family. We're trying to build an equal, intimate relationship, connect the emotion tie together. But the most important, we're trying to build a new way to live, to think, to feel in the process of urbanization. So that's some of my thinking. Thanks for your listening.
Thank you very much, Dr. Ren, for this inspiring point of view. I remind again that the symposium is an activity of special interest group, and particularly I would like to thank you, our secretary, Professor Constantin Bella, and our advisor, Professor Alma Jimenez. And if someone is interested in joining this group, feel free to contact me or Vanessa.
For anyone who has some queries, the floor is now open for questions. For the Demétrius, he's online. And for Katerina, she's face to face.
And for Vanessa too. Not for me.
my bosses are all here.
It's just a comment. It's a comment on the paper of Dr. Cainghug, Vanessa. The situation that she describes, well, her formulation is that the conditions around COVID triggered the suicide attempts of the two cases she presented. But we're saying that and we agree with that, but what we need to state clearly is that if it weren't for pre-existing psychiatric morbidity, the impact of the trigger would not have been to that point. Also, the lack of clarity, the social support system, the family dysfunction, was the fact that they could not rely on anyone else but themselves, and their family was dysfunctional. I think made the impact of family dysfunction that much more.
Thank you for that comment, Doctora. I agree very much with you. And also, I'd like to stress that the family dysfunction was heightened also by COVID because I believe that the family, the marital stress between the mother and the father was, COVID also contributed to that because the father was very stressed, leading to the affairs. And then, since the family was in a closed environment, the stress could not go up.
Yes. Also, I think that is an important question because I also think I want to ask you what is the role of involved family in the treatment. Because you talk about two, also Katerina and also the other, two cases, no? And
Yes.
in particular, one of them, you work with family a lot.
Yes, of course, because our group is involved with adolescents and young people, and as we all know, young people or adolescents are still dependent on their families. And in our country, in the Philippines, it is extended. Adolescence is extended. Actually, it's now 21 years. So the family has to be involved in the treatment. The treating psychiatrist not only sees the patient, but we also have to deal with the family to help them be more involved with the patient and to help change the way they interact with the patient. Thank you.
I don't know if Katerina would like to add something about the role of the family. If you think that in all situation it needed a family therapy or something different, case by case.
I think that in most of the cases of my child and adolescent patients, is the family therapy needed because the children are living very often, as I mentioned in my presentation, in very dysfunctional families, and they are facing often domestic violence or some difficulties in the relations between the parents and also between each of the parents and the child itself. So I think it's very important, but unfortunately we haven't enough of these services in our country.
Please.
I'm working as a psychiatrist in Melbourne, in Australia, and I work primarily with young adults, 18 to 25. So, COVID, yes, we had big issues. We had a very long lockdown. I think Melbourne had the longest lockdown of all the cities in Australia. Lots of problems with families being stuck at home, mum and dad under financial pressures, children trying to study from home, everybody fighting for the internet. What I'm interested in is in the Philippines and in Czechoslovakia, a common scenario we have. I work in an inpatient ward, so we have young people come in following non-suicidal self-injury, first episode psychosis, first episode mania, severe depression, or they have gender, sexuality issues. Common request I have is, please don't tell my parents, please don't tell my family, and we have to balance with, there's a lot of human rights and there's a lot of advocacy for young people to individuate, to have your own autonomy. So we struggle a lot. Personally, I'm a little bit paternalistic. Under duty of care, I will explain to the young person that I will contact your family. I give them the reasons, and sometimes I actually tell the young person what I will actually say to the parents and check in with them. Is that okay? I wonder if you have the same issues where you work.
Doctor, I'd like to tell you that we have the same dilemmas. we also do the same. We also use the same approach as you. But personally, I specifically tell the patient that I'm only going to tell your parents anything about what we talked about if I feel that your life will be in danger. And then for any other items which I will tell, I have to inform you first. Very similar to the Philippines. What you Brad?
Sometimes I have the feeling if I'm working with the adolescent or children, that the parents are bringing their children to the hospital or outpatient clinic, and they are just telling us, my child is ill, something is wrong with my child, and please help them, repair them. And I think that usually they don't realize that usually something wrong with the whole family system, so not only with the child as an individual, but because we can't separate him from the whole family.
Thank you so much. Yes, Laura.
Yes, I had a question for Katerina. I was wondering, do you cooperate with social services, and to which extent?
Yeah, so we are trying to cooperate with social services, but sometimes it's very challenging because we haven't enough of community-based social services. So most of the social services are public, and they are usually have the tendency to lock these children with with some borderline features who are mutilating themselves to some residential facilities, and so they don't have this approach, but we are trying to develop it, to work with the families really in their natural environment, so in the directly in the family. We have quite developed system for psychotic patients, and then we have more of these mobile teams. They are going to the families and working with the family members of psychotic patients, but it's not much developed for children and adolescents, unfortunately. So it's a task for future.
Thank you, and thank you for a wonderful presentation.
Thank you.
Thank you.
Yes, please.
I have one more question to my favorite Dr. Cainghug.
Please.
Yes, you made the point in your presentation of distinguishing case A and case B, and you pointed out that, now I can remember, one family responded well and the other did not.
No, doctor. Both were responsive, but case A, it took me a lot of work for them to respond.
Okay, so I just would like to draw out from you what lessons did you learn about how psychiatrists can manage such situation.
Okay, thank you for that, Doctora, because this was really a challenging case for me. I've been working with children for about almost 20 years, and this has been my most challenging case so far. I realized that with this case, I used everything which I know, but I also realized that I really need help for myself. I had to ask my colleagues for supervision, and one of my supervisors is here. in the person of Dr. Ren, I had to be supervised by them almost every week. That's all. And but I also realized, Doctora, that we do make mistakes in therapy, but we can go back and correct them. Because I made several mishaps, but then I came back and corrected them.
Do you care to share with us? Just the ones that you
Because okay. Because I mentioned that this family was very unique. So they had a spokesperson who was a doctor, a pediatrician, who was the aunt of the patient. And since she was the family spokesperson, I had to really relate to her. And she requested that I have a session with the grandfather. And then I did not realize that the wife of the grandfather took that negatively. My session with the grandfather. And she exploded in front of me. That was the most difficult situation, but I managed to repair that. After 2 days, when I went back, she was very angry already.
So it seems that the different family members we're not all on the same page.
No, no,
About how to accept
no. They had various opinions, and they also come together or against each other.
so that was very challenging for you because you had to level the expectations of everyone.
Yes.
That took a lot for you.
It did, Dr. Even until now, because I'm still seeing the patient on an outpatient basis, but now online because of the problems, her physical problems, since she cannot go to the office. In fact, during her first few weeks after she was discharged, for her to follow up with all her doctors, she would get admitted for 1 or 2 days, just so that doctors can see her for her follow-up. That was how difficult it was.
Thank you.
Okay. Please.
This one is a example because I also know these things as Vanessa mentioned. It is not the point of the difficulty or the difficulty of managing child in the adolescent patient. It's always in the context of family, and they are not to be seen as individual adult patients. It's always the family is always involved, and you always have to tread carefully every time as the case you have presented, even the other one, the easier one that you mentioned. There are always some, 1 or 2 people in the family, especially for Philippine families, where it's super extended.
Yes, yes.
Even the maids,
Thank you for mentioning that, Dr. Arnold. In case A, the nanny had a very major role because she was the only person in the family that the patient had a very stable attachment, because her attachment to all other members, including her parents, was not good. So I also had to work extensively with this nanny.
No more questions for Vanessa? Or for Katerina? Okay. Thank you so much, and enjoy your conference.
Thank you so much.